Dr. Chris Shaver here at the GI Show. Hope you are doing well, and we're glad to have you for what I think is going to be a really, hopefully, educational, informative episode on GERD, G-E-R-D, gastroesophageal reflux disease. So we're going to be talking about that today. Remember, the GI Show brings GI to the masses. It's designed to inform and educate you about common and sometimes not so common diseases of the gastrointestinal tract. So I've got a special guest for us today, Dr. Raj Parikh. He's going to be with us. I've known Raj for a long time. He is a board certified gastroenterologist and a good friend. We've practiced together for a long time. Now we are here, I'll bring him on in just a second and we'll talk and we'll get to know Dr. Parikh. We are here today at the lovely BGA Studios and brought to you by Birmingham Gastroenterology. Check them out, including more information on reflux disease at bgapc.com. If you're watching this on YouTube, subscribe to the GI Show and like us. We'd love to answer any questions you have too. You can follow us on Twitter at the GI Show at ShaverCP. So Dr. Parikh, please join me, good sir.
Thanks for having me, Chris.
Good to see you, and welcome to your premiere time on the GI Show. We're glad to have you, and welcome.
Appreciate it. Glad to be here, and hope we can spread some good information to all our patients.
So talk to me a little bit about patients who we would maybe label as having refractory GERD, because I consider those patients a clinical challenge.
Yes.
In a lot of ways, because darn it, you got heartburn, and these medicines block acid very well, and so why is that heartburn not getting better? So talk to me about sort of how you sort of confront that kind of issue.
Yeah. So I think there's two roads you can go down, which I always do for patients with what we call refractory, or not responding to therapy, typical therapy, reflux or heartburn. One is it something else? Are we totally got the wrong diagnosis here? You know?
Yeah.
Could it be something in the chest, heart, an allergy?
We get to play cardiologist
Food
sometimes,
allergies,
don't we?
yeah.
We get to send patients.
Absolutely.
You know, and we identify. We've diagnosed coronary artery disease,
Yep.
and even MIs in my practice that were initially thought to be an acid problem.
Yeah.
So that's a great point.
This is taught early in med school. You know,
Yeah.
a woman with GI symptoms don't miss coronary heart disease.
That's right.
It's
a very
commonly
good point.
how women present.
Yeah.
So that's a big one. Do we have the right diagnosis?
Right.
And we have a lot of diagnostic tools to confirm this. You know, with endoscopes and acid monitoring, which we can talk about in a bit. Manometry, checking your muscles, and it's not just, hey, let's just throw meds and see what happens. We will evaluate you and confirm this diagnosis. I think that's number one, the most important thing. And then there's the truly refractory. That's the other road we can go down, where you have just terrible reflux. And reflux is so much more than acid reflux. You know, there's a lot of things in your stomach. There's food, liquids you've drank, there's bile. So these things, while not acid, you know, and these PPIs and H2 blockers that we use for GERD and acid reflux, they do great to reduce acid, but none of these other things. It doesn't address your muscular function of your esophageal sphincters, the round muscles in your esophagus that should be controlling what goes in and what goes out.
So that's a good point. And so that makes me think of this question. So you have a patient, Dr. Parikh, that comes into your office and it's heartburn. We don't think it's cardiac. Their lungs are clear. This is a healthy patient. And so let's just say they had an endoscopy already and it looked pretty normal. And the biopsies were pretty unremarkable. And so we're a little bit, and they've been on twice a day reflux medication, PPIs, and they take antacids still.
Yep.
And they've done a lot of the other lifestyle modifications that we've talked about, and they're thin.
Yeah.
So talk to me about kind of what do we have in our toolkit to maybe sort of go a step further and maybe sort of reassess this situation and look into what else could be going on here.
Yeah, so there's a lot of tools. One is acid monitoring called pH studies or impedance studies. That's one tool we use frequently. Sounds a little funny and maybe sometimes a little scary, but it's not too bad. We can actually implant a little chip in your esophagus and measure how much acid reflux we're having. We can do this on medication, off medications. There's different reasons for that, what we would talk about, to confirm our diagnosis.
That's right.
There's imaging tests that we can use to see if there's something in the chest cavity. There's a lot of organs, there's a lot of important things right here that we can evaluate with imaging. There's a quick, non-invasive, as an endoscopy or surgery. What other things are you thinking about?
Yeah, that's good. I think that's right. So let's say, I'm just going to walk us through this scenario. So you mentioned, so let's say we do a pH study on this refractory heartburn case. And we do it, because we're really kind of stepping back here, we're going to do it off of acid suppression. We're going to hold the Nexium for 7 days.
Yep.
And put in our Bravo capsule and get 48 hours worth of pH data. And we're going to analyze that. And let's just say that comes back, and we're not going to get into sort of symptom correlation. That's again for another more targeted discussion. But let's just say that test came back normal.
Right. And
this patient, while having this heartburn and having even food sensitivities and being frankly somewhat miserable, kind of where do we go from there? Do we have a sort of another approach to sort of treating this type of heartburn?
Sure, yeah, absolutely. So, in addition to that acid, when we put this little chip in, we'll actually look at the anatomy too to give us a little bit of a clue.
Okay.
Do we see like mucosal damage or lining? Do we see any damaged Barrett's? Do we see a big hernia? Which I haven't really gotten into yet,
Yeah,
but hernia and how your stomach kind of pooches up into your chest can really affect people's symptoms. But if there's not mucosal damage and this pH study is pretty normal, we look for, like you said, other causes. Could it be reflux and just hypersensitivity? Can it be functional pain?
Like functional heartburn?
Yeah, absolutely. That's a big one. And there's various ways to treat it. Sometimes acid reduction is part of it, but there's a whole host of other things we can try to treat that.
Yeah, that's right. And so I think the take-home point with that is not everything that produces heartburn is acid reflux. And within the acid reflux camp, there are varying degrees from just Barrett's esophagus, esophagitis, to kind of low acid reflux or hypersensitivity. So we see a spectrum of disease, and unfortunately, not everybody is going to respond.
Right.
And we end up seeing a lot of those patients who have done sort of everything that, from medications to lifestyle modifications. And sometimes we have to kind of do additional testing to get to the bottom of things.
Absolutely. And one thing we didn't really mention is your muscular function. Sometimes spasms of the esophagus can cause a lot of this discomfort. And we have some tools that we call manometry for that, which is not used often, but in the right scenario can be a very valuable tool.
Yeah, and those patients will also present often with dysphagia.
Yep.
Not always, but they'll also present with difficulty swallowing as well.
Yeah, those are those referrals we get from the cardiologists a lot. We get that.
A lot of chest pain with that as well.
Yep.
That's true. Okay, so kind of good review of treatment, medical treatment, lifestyle treatment.